Hello, everyone. Thank you for joining us today for our webinar entitled 2020 MIPS Participation Without an EHR. Today's presenters are Bruce Mackey, Alterum's Regulatory and Incentive Program Analyst, and Candy Hansen, Program Manager at Stratus Health, one of the great partner organizations of the QPP Resource Center. Bruce and Candy are also joined behind the scenes by three other colleagues, providing additional subject matter expertise. Deb Gorey from Northern Illinois University, Chris Becker from Metastar, and Kevin Perdue from Alterum. My name is Liz Jones, and I am today's moderator. Before we begin, I have a few housekeeping items to touch on. A PDF copy of today's slides, as well as several other resources Bruce and Candy will reference during the broadcast, can be downloaded right now from your GoToWebinar interface. We will be keeping everyone muted during today's presentation. If you have a question for the panel, please type it into the questions box in your GoToWebinar interface, and it will either get answered by Deb, Chris, or Kevin during the broadcast, or we will address it during the Q&A portion at the end of the presentation. Because of the large number of attendees for today's webinar, we may not have time to answer all of the questions. If we do not address yours during today's broadcast, you will receive an answer through email. Also, a link to the recording of this presentation will be available soon on the events page of our website at www.qppresourcecenter.org/events. Today, our panel of program experts will discuss how clinicians can participate in the MIPS program even if they don't have an EHR, taking a look at how scoring is affected, quality category reporting criteria, the EMA process, benchmarks, implications for using topped out, capped, and inverse measures, as well as the points needed to avoid a penalty. Finally, they will wrap up by discussing the various reporting options available to non-EHR participants and will share a host of valuable resources you'll need in order to be successful in MIPS in 2020. Following the presentation, and if we have any time left, the presenters and panelists will answer any remaining questions posed by the attendees. Please note, the information you will hear in this broadcast is current as of today and is only intended to be a general summary. With that, I will turn things over to Candy.
Thank you, Liz. So just want to do a quick sound check. Can you hear me okay?
We can.
Okay, perfect. So this slide is just showing you what a comparison looks like of what your scoring will look like without an EHR. We wanted to do this presentation because it is still possible to at least have a neutral payment adjustment in the 2020 performance year without having an EHR. And in fact, it's even possible to get a very small positive payment adjustment. Small practices in the 2020 performance year continue to receive the 6-point small practice bonus if you submit at least one quality measure. So you automatically get 6 points for just being a small practice. The quality category is reweighted without an electronic health record to 70% from the promoting interoperability category. We'll talk about applying for that exception shortly. Improvement activities, that weight has not changed. However, there are 2 new activities for 2020. 15 of the activities have been removed and 7 of them have changed. So you'll want to pay attention to the improvement activities, what the activities actually are for the 2020 performance year. The other major change for this year in improvement activities, where it used to be if you were more than one clinician, you would receive credit for the improvement activities category with only one clinician doing the activity for the group and receive credit for that score. However, beginning in 2020, 50% of clinicians in the group need to actually be performing the activity to receive credit and the score in the improvement activities category. Beginning in 2020, let's see. Oh, you'll need to get 45 points in order to receive a neutral payment adjustment for 2020 versus 30 for last year. And the exceptional bonus category threshold is now 85 points. For the cost category, you don't need to submit anything again for this year. However, there have been many more measures added to the cost category. So you'll want to be paying attention to the report that comes out about mid-year that details information about your costs. Next slide. So for the quality reporting category, things haven't changed. You still are required to submit 6 quality measures. Of course, first an outcome measure if you have one, but if you don't have an outcome measure, you should have a high priority measure. If you don't have 6 measures to submit, you can choose from a specialty measure set, of which there are many. And if you do submit to a specialty measure set that has less than 6 measures, you must report on all of the measures in that measure set. Data completeness for the 2020 performance year has been raised from 60% to 70% of the patients who qualify for each measure. You still receive 3 points, however, if your data completeness is less than 70% as a small practice, and the minimum case requirement remains at 20 cases. You can use data using different data submission types. So EQCMs, that would be previously known as submitting through an EHR. You can do MIPS QCMs, which are MIPS clinical quality data measures, or a qualified clinical data registry measure. You can submit via claims, which we'll talk about in just a moment. And then, of course, the option of the Consumer Assessment Healthcare Providers and Systems, or the CAPS for MIPS survey. So for potential bonus points, you can get up to 10% for submitting 2 or more outcome or high priority quality measures. Remember, the first high priority or first outcome measure that you submit is the qualifying measure, so you don't receive additional bonus points for the first one, but you can receive additional ones for 2 or more. And then 6 points, as I just mentioned, for clinicians in small practices who submit at least quality measures. There is, if you submitted data for the 2019 year, there are performance improvement points that you could qualify for, up to 10 points over from your 2019 quality score for improving on some of those quality measures. And then there continues to be the complex patient bonus. Next slide. So the question comes up, what if I don't submit 6 measures, or what if I didn't think I had 6 measures? So there is the eligible measures applicability process in place. This process has been named, the name has changed a little bit over the years, but basically what it is that if your measures are reported through Medicare Part B claims or MIPS QCMs, and you reported fewer than 6 quality measures or no outcome or high priority measures, the process could determine if, in fact, there were other measures that you could have reported, or if there was an outcome or high priority measure that could have been submitted and wasn't. And if it isn't, if they do find that that is the case, they will adjust the scoring to reflect the number of available clinically applicable measures. And that link that is listed on that slide is a CMS video on the EMA process in general. So generally, the EMA processes apply pretty much for this audience to specialists and subspecialists. So that's just something to keep in mind, that you'll really want to take a look at your measures to make sure that you're not missing a measure that you could have reported. Next slide. So benchmarks. How do benchmarks impact scoring? So your performance on each quality measure is assessed against its benchmarks to determine how many points each measure has the potential to earn. So in general, measures that meet the data completeness standards and the case minimum requirements are awarded 3 to 10 achievement points. And so benchmarks can be most easily understood as things that are derived from past performance reported from all clinicians in prior years. So if you think about clinician performance that's compared against the average performance of all clinicians over a period of time, that's how benchmarks actually get established. And next slide.
I think it's also important to note that these benchmarks change from year to year too, because with each year of reporting, they have that additional average performance of clinicians. So as that average performance changes over time, those benchmarks will change over time as well.
That's a great point, Bruce. Thank you for bringing that up. So here's an example. So there is a benchmark file that you can find at the CMS, and I think we've got the links to that not only in the slide deck, but I believe at the end of the slide deck as well. But on the QPP CMS resource page, you can find the benchmark file. And the other point to bring up is that benchmarks vary from reporting method. So the benchmarks for one reporting method, for example, MIPS QCMs versus EQCMs, your benchmarks are going to be different. And so looking at your benchmarks and the reporting method that you're choosing is an important determination in determining, potentially how much can you score for each measure that you're going to submit. So here's an example of a MIPS QCM measure with a benchmark that can be reported through a registry such as MIPScast. So you can see in this example, if you have a perfect performance rate of 100%, you'll earn 10 points for the measure. However, if the measure or if your performance rate is 48.66 to 76.99%, the score falls in decile 6, which means you would earn between 6 and 6.9 points for the measure, depending on the numerator that you entered in for the denominator for the measure. And again, here's the link to download the 2020 MIPS Historical Quality Benchmark spreadsheet. And so you can get to those benchmarks through that link.
I've also loaded them into the webinar's handout section too. So if you don't want to click on that link, you can go to the GoToMeeting handout section, and we've loaded this and a few other resources right there. So you can just click on that and download them there too.
Great. Thanks for bringing that up, Bruce. Next slide. So how do benchmarks impact scoring? So that's why it's important to really look at your benchmarks of the measures that you're actually choosing for the method that you're going to submit. So 196 quality measures can be reported, of all of the measures that are available, can be reported through a registry such as MIPScast, of which 53 are without benchmarks in 2020. So if you choose measures without benchmarks, you're basically choosing the lowest possible score that you could receive, which as a small practice would be 3 points per measure. And so you're not optimizing the amount of points that you could get per measure, which then of course impacts your final score. And remember that just because there are 193 eligible registry measures, each registry determines how many of those 193 measures that they will support. In this case, MIPScast supports all MIPS QCM or registry measures, as well as all EQCMs. And many registries and QCDRs do not. And basically they kind of determine that by offering a subset selection in line with a particular specialty. All right, next slide, please. So topped-out measures. Topped-out measures are those measures whose performance is such that there really isn't much room for improvement anymore. Mostly that's because the activity has been done, that has been done or is being done has sort of become a standard of care. So there's really not a lot of room for improvement. And if you look at columns O and P in the 2020 quality benchmarks file, that will tell you whether or not a measure has been topped out. The reason that that's important to understand is in the performance year that you're in, if a measure is topped out, it can only receive 7 points as opposed to 10 points for a particular measure. And also topped out measures kind of go on a schedule, if you will, that eventually they can become measures that aren't even offered in future years because they have become such a standard of care. Bruce, anything to add on topped out measures?
No, I think, it's getting harder and harder to avoid them, but I think you'll find that trying to, anyway, avoid the topped out, and especially avoiding those ones that are topped out and capped at 7, can really make a huge difference in your overall quality category score. Again, it's getting harder and harder, with each passing year. As that average performance increases, we're seeing more and more of these measures get topped out. And then as Candy mentioned, if they're topped out for consecutive years, CMS is just dropping them completely because, again, there's no discernible difference between the highest and lowest performers anymore.
Correct. Next slide. So this is just an example of an inverse measure. There's only a few inverse measures, and I'm not sure if our panelists actually know right off the top of your head how many there are, but there aren't very many inverse measures. But you still want to pay heed to them because inverse measures are you'll notice that the lower the score, the better. And so just understanding which measures are inverse also helps you be able to maximize and optimize your potential measure score. Next slide. So as I mentioned before, in 2020, the 45 points are needed for the neutral payment adjustment. So the way the scoring works and the weights work is kind of in some ways a little bit hard to understand. So in the maximum for the improvement activities category, the maximum improvement points that you could earn are 15. But you'll note that your quality is weighted at 70%, but there are net points and there are gross points, and the gross points are your performance category points, and the net points are the points that are actually counted towards the MIPS final score. So the gross points times the category weight is how you determine actually how many points you actually earn in the quality category. So for example, 42.86% gross points equals 30 net points needed from the quality and cost categories. Again, quality is being weighted at 70% because the promoting interoperability exception application has been submitted and approved because you don't have an EHR. So it gets reweighted over to the quality category. The cost score, again, that's an unknown during the current performance year because it is calculated based on adjudicated claims throughout the performance year. And again, small practices can earn a 6-point bonus in the quality performance category, which actually multiplies or is actually calculated then or weighted at 4.2 points to the MIPS final score. And I know that's kind of confusing in how those are calculated out. Anybody have anything to add on those?
No, I think, again, we do see this, we see people trip up on this a lot, kind of converting that performance category points into the MIPS final score category points. So again,
right,
as Candy mentioned, and I'll just reiterate, you take, whatever that category, you take what you're earning within the quality category, and then you multiply that by whatever percentage your quality category is weighted at. So if it's at 70%, you're going to multiply your category score times 0.7. And that converts that category score into the number of points that you're going to earn in terms of a MIPS final score.
Correct, correct. Next slide, please. So again, 45 points are needed for a neutral payment adjustment. So it's important to plan your work and work your plan. You're going to want to make sure that you're doing careful planning and copious record keeping so that you have documentation of everything that you've done in the quality payment program. Certainly you want to pick the measures that are most applicable to the practice, to your practice, and also to your workflow, and start planning and documenting now. So the quality category, so for improvement activities, you can do that. You can perform that activity for any 90-day period in the 2020 performance year, but the quality category is scored across the entire performance year, which is the entire calendar year. So best practice advice, every small practice clinician should submit a PI exception application because it creates that safety net. So, you know, you can decide later if for example, you ended up getting an electronic health record mid-year, et cetera. You could decide if you still wanted to do that PI exception. And so just as a safety net, just go ahead and file that PI exception so that you have that already in your pocket as you're going through the performance year. So next slide, and then Bruce is
I think if I
going
go to
to
the next
take over.
slide. Yeah, I just wanted to kind of say, you know, while there's 4 bullet points here, I really can't stress enough how important these ones are, especially for those folks that don't have that EHR. And so, you know, their EHR isn't taking care of calculating those CQMs for them. You know, we really can't stress enough how important it is for those non-EHR users to really carefully plan, and we can't stress enough how important it is, you know, that copious record keeping is needed. We'll touch on that again as we get further into this. We've got some kind of chart extraction examples and whatnot too. But yeah, if you're not really planning and documenting right now on all of this, you're going to find yourself at a huge disadvantage later this year.
Absolutely.
All right, so I'm going to go through the next 3 kind of bullet points here. We're going to talk about facility-based scoring, and then get into kind of what it takes to do that Medicare Part B claims reporting and registry reporting. Those are, if you don't have any EHR, those are really the 2 data submission methods that are open to you. So we'll kind of dive into each one of those as well. But before we do, I've got a few things to keep in mind. First and foremost, we know that CMS is going to make some sort of accommodations for the COVID-19 pandemic that we're all living and breathing right now. But we don't know what that is yet. I've got some guesses on what I think CMS is likely to do for 2020, but I'm going to keep those to myself so I don't kind of steer you guys down the wrong path. We hope to hear from CMS really soon on what they're going to do for the QPP. We just don't know what that is yet. So stay tuned. You know, I would suggest, you know, if you're not already subscribed to our listserv, you know, anything that comes out, we'll make sure we send it out through that. I would also encourage you to sign up for CMS's listservs for the QPP program, so you get those notices a couple of different ways. Also, we know that the maximum payment adjustment is plus or minus 9%. It's definitely minus 9%. We also are definitely not going to see as much as a 9% gain on your Medicare reimbursements for this program year. So that plus or minus 9% is how the regulation was written, but it is a budget neutral program, meaning the folks that are getting incentivized, the ones that are getting positive payment adjustments, are that being funded by the folks that are getting penalized. And so just like we've seen in previous years, if we don't have enough folks getting penalized, there's not enough money on the top side to pay out those bigger reimbursement increases. So on the books it says plus or minus 9%. We're definitely not going to get plus 9 out of it this year again. That will come in future years. I think as we get through the transition period, we'll start to see those massive gains in Medicare reimbursements for those top performers. But if you do not participate and you're supposed to, you absolutely will get a negative 9% in your Medicare reimbursements. The payment adjustment year is always 2 years after the corresponding performance year. So if we look at 2020 as our performance year, you are working this year to protect your 2022 Medicare reimbursements. And you definitely don't want to take a 9% pay cut. If you had planned on submitting data through claims, but you haven't started it yet for 2020, all is not lost, although you absolutely want to jump on that immediately and get going. You can either elect to either report through a registry or through both Medicare Part B claims as well as registry reporting. And there's certainly some logic there to really cover your bases and use 2 different reporting methods to make sure that you can get the data you need to CMS. To achieve 3 or more points per measure as a small practice, data completeness must be at least 70%. Candy kind of referenced this data completeness concept earlier a few slides ago, and I'll kind of explain this a little bit better here. So data completeness looks at, it's this measure that CMS ensures that you are applying that quality measure to a certain percentage of the patients to which that particular quality measure applies. It's sort of a confusing sort of concept. The standard example I like to give is the NQF 59. I think we used it earlier in this during the benchmark slide to show you an example of how the benchmarks work. But the main diabetes A1C performance measure. It's also one of those inverse measures, by the way. So that measure is looking at all of your diagnosed diabetics. And then you have to ensure that you are reporting on at least 70% of that patient population. If you're claims-based reporting, it's 70% of your Medicare patients. If you are registry reporting, that is 70% across all payers. So it's not just Medicare if you're registry reporting. If CMS knows who your Medicare diagnosed diabetics are in that example, and so they know what your data completed. They know how many patients you should be reporting on through claims. If you do not report on at least 70% of those diagnosed diabetics in that one example, you're only going to receive 3 points for that measure, no matter what your performance was on the ones that you did report on. So data completeness is a very important concept. You'll, you could be doing phenomenally, but if you only report on 69% of those Medicare patients, you're only going to get 3 points instead of up to 10. All right, let's talk a little bit about facility-based measurement scoring. I think this is a good way to get around the fact that you don't have an EHR. If you qualify for it, this could be your kind of silver lining. This could be what gets you out of a lot of work in terms of quality reporting, and it could potentially give you a pretty good quality and cost score as well. So what facility-based measurement scoring does is instead of using the clinicians, like practice reported quality and cost, it looks at the hospital's value-based purchasing, or VBP program, earned by their assigned facility. So some clinicians are deemed facility-based, and if you are facility-based, then this could be an option for you. Individual ECs qualify as facility-based if they bill 75% of their covered professional services in a hospital setting. That looks at place of service 21, 22, and 23. You also have to bill at least one service to the inpatient hospital code, the 21, or to an emergency room, 22. And then you also have to be assigned to a facility that gets a 2021 hospital VBP program score. Note, however, and this is sort of a sticky point, and these programs don't necessarily line up well. The CMS is going to use the fiscal year 2021 VBP score, but those scores are not available before December of this year. So if your assigned facility doesn't get a VBP score, you won't know that happened until it's too late for you to get your own quality data in. So I wouldn't necessarily fall completely on, banking on that facility-based scoring, because some things do happen. Your assigned facility might not get a VBP score, or it's a really bad one. There's a lot of things that could happen if you just bank completely on facility-based scoring. So I wouldn't necessarily advise you to do that. I would say have a safety net where you're reporting your own stuff too, even if you're pretty sure you're going to get facility-based scoring instead. Because if something happens and suddenly your facility doesn't get a VBT score, if you don't have your own data submitted through claims or through a registry, you're going to take a payment penalty, and you don't want to do that. Groups and virtual groups can also qualify, and we've got the qualification there. 75% of the clinicians are qualify as facility-based measures as individuals. The easiest way to find out if you are facility-based is to go to the QPP NPI lookup tool. There's a link there on the screen, but it's built right into the main CMS QPP website at cms.qpp.gov. I'm sorry, qpp.cms.gov. So click on the go to the lookup tool, and really what you're drilling down to is the other reporting factors. That's going to so expand the screen once you pull up an NPI and kind of scroll down, and here it's going to indicate if the clinician is hospital-based, non-patient facing, small practice, and lastly facility-based. Also note that hospital-based is not facility-based. These are two separate designations that also get confused. Hospital-based has a slightly different calculation that adds one additional place of service. So as facility-based looks at place of service 21, 22, and 23, hospital-based also pulls in place of service 19, those off-campus outpatient hospitals. So just because you're hospital-based doesn't necessarily mean you're also going to be facility-based. You want to make sure that you see that facility-based designation under your NPI. And if it says that you are facility-based, it will also generally provide the facility that the clinician is assigned to as well.
Bruce,
so CMS is going to, yeah.
Since you brought that up, why don't we explain what it means to be hospital-based? What benefit is that to the practice to be hospital-based? Is there a benefit?
Go ahead. Yeah, if you want to expand on that, feel free.
No, because you brought it up, I thought that you would want to do that, so that's okay.
Yeah. So again, hospital-based just means that really the vast majority of your claims are coming through those through the hospital and through those 4 places of service. And so if you don't have all those, you have to have a really significant amount of your claims going through that hospital to get that designation. Same thing with facility-based. It just looks at your overall amount of claims, and if a certain percentage of them are through those places of service, you'll get one or the other of those designations.
Right, but
so,
there's no
CMS,
other way to score in a hospital-based setting, correct? You're still going to there's no other way to submit when you're hospital-based. It's just an informational thing, right?
Yes, that's correct. So CMS is going to automatically apply facility-based scoring to any clinicians and groups who are eligible for it and who would benefit from it. So it's going to automatically happen behind the scenes. So CMS is going to try and score you as facility-based if they can. There are no submission requirements for the individual clinicians to have this happen, but if you are group reporting or you would like to be assessed as a facility-based group, you do have to signal to CMS your desire to be scored as a group. The way you would do that is to submit data for the improvement activities or the PI program, which doesn't really apply to this group since you don't have any EHR. So really, you'd need to ensure that you submit improvement activities through the QPP portal at the group level. That signals to CMS that you intend to participate in the program as a group, and then they will try and apply facility-based scoring at the group level for you. And it's really important, I talked about this, using that safety net. I wouldn't rely solely on facility-based scoring. You could also outperform your hospital. It's possible on their score. If CMS can do facility-based scoring for you, and you also submit your own quality performance data, CMS is going to look at both data sets and they're going to award you with the better of the two. So I would encourage you all to not fall back solely on facility-based scoring for those couple of reasons. One, your facility might not get a score, or they might get a bad score. And so you want to also do your own reporting, and then CMS is going to take the better of the two. I do have a link there to the 2020 facility-based quick start guide as well. There's some good information in there to expand upon everything you just heard.
All right.
All right.
So, okay. So now we just thought, yep, no worries, Bruce. So we thought it would be important to just take a few minutes here to just do a little bit of deeper dive into what the specifications are and how they're broken down, just to make sure that when you're looking at your measures, not only do you choose a measure based on its benchmark and whether or not it's been topped out, but you really want to pay attention to the details of the specifications for the method for which you're going to report. Next slide. So for Medicare Part B claims, there are 55 quality measures available to submit through claims. The number of claims measures that have been available has historically been being reduced because CMS would like everyone eventually to report electronically or through a registry. But for the 2020 year, there are 55 measures. 5 are outcome measures. And 32 are high priority, so you do have an opportunity to choose the measures through claims that will earn you, or that can earn you, some additional bonus points. 13 of those 55 measures, however, do not have benchmarks. So there again, that's why you're going to want to be checking that benchmark file. You're going to reference the specifications for your measures selecting, or for the measures that you're selecting. And when you're filing that claim, you want to check the specification sheet to make sure that you've coded it correctly, and that you have all of the details of what's required to use Part B claims to report on the 1500. And the HIACF just stands for Health Insurance Claim Form if you're not familiar with the 1500. And you can use claims as a small practice, either as an individual or as a group, because you are a small practice. Next slide. Oh, and then we've listed this claims measure specification sheet URL there as well. So, so we've broken out the specifications. So we've chosen measure 236, controlling high blood pressure. And so it asks you, it starts by saying there are 3 qualifiers in order to use measure 236. Is the patient between 18 and 85 years of age on the date of the encounter? Does the patient have a diagnosis of hypertension that overlaps the measurement period that we'll talk about in just a minute? And is the encounter code for the patient that you're seeing one of those particular encounter codes? If the answers to those 3 questions are yes, you can continue. If not, the patient isn't eligible for that particular measure. Next slide. And we're not going to go through and read every single detail of the specifications. We just wanted to make sure that you're paying attention to the specifics of each individual measure that you're choosing. So again, the denominator will be all of the patients that you're doing claims for that are Medicare patients that are between 18 and 85 years of age, who have that diagnosis and that overlap the measurement period and meet the criteria for the particular encounter code. Next slide. So this measure is to be submitted a minimum of once per performance period for patients with hypertension seen during the performance period, which is 2020. The performance period for this measure is 12 months. The most recent quality code submitted will be used for the performance calculation. And if no blood pressure is recorded during the measurement period, the patient's blood pressure is assumed not to be controlled. Next slide. Okay, so the numerator for this particular measure is patients whose systolic blood pressure is less than 140 and whose diastolic is less than 90 during the measurement period. So only blood pressures performed by a clinician or a remote monitoring device are acceptable for the numerator to be in compliance with this measure. And then there's a couple of other qualifiers. As I mentioned before, if no blood pressure is recorded, the patient's blood pressure is assumed not under control. And if there are multiple blood pressure readings on the same day for some particular reason, you want to use the lowest systolic and the lowest diastolic reading as the most recent blood pressure reading to receive proper credit for that particular measure. Next slide. So here are some exclusions from the denominator. Again, I'm not going to read them all to you, but just so that you know that there are some exclusions. For example, if hospice services were given to the patient at any time during the measurement period. Next slide. And again, here's just one last exclusion that would exclude a particular patient from the denominator for this particular measure. Next slide. So again, you're using numerator codes and denominator codes. If you're on the claims form, on the 1500 claims form that you are going to be filing for the particular measure. And the next slide. This document, actually, it's hard to read. I just wanted to do a snippet of it to show you. This is actually from the Claims Quick Start Guide that also can be found on the QPP Resource Center. And again, it's just making sure that you're paying attention to the particular claim details. For example, making sure that you put that 0.01 penny in your G codes to make sure that CMS is knowing that you are filing this as a reported measure for the quality payment program to make sure that you get full credit for each measure using claims. Next slide. Bruce?
Okay, so next we'll go through the registry reporting requirements. So again, you want to use the 2020 MIPS historical quality benchmarks file, which you can download right now in the handout section. To identify those measures that are most appropriate to your practice. You want to filter that file by MIPS CQM. That is what CMS calls their registry measures these days. They're called MIPS CQM measures. And they can be submitted through a qualified registry or QR that like MIPSCAST. Again, MIPSCAST is our own qualified registry. It is our own, you can access it for free through the QPP Resource Center if you are a small practice. A lot of you are already working with us and already have access to that tool. MIPSCAST is really, think of it as like a sandbox. We have mimicked what CMS does and how they score all of the data under MIPS for across all of the categories. And so you can use it as a tool to figure out how you're going to score this year. Again, it is free to anyone who's a small practice, and a lot of you I know are already using it. We also have the Qualified Clinical Data Registry. So the two hyperlinks there for the Qualified Registry and Qualified Clinical Data Registry is going to download CMS resources if you click on those to give you lists of each one of the QRs and QCDRs that are out there. So you can kind of shop around if you're not going to use MIPSCAST. There are a lot of them available to you. However, it's really important to note that, and we already touched on this a little bit, not all of the quality measures that are available to submit through a registry are supported by each one of those QRs or QCDRs. MIPSCAST does support all of them, but you'll find a lot of them kind of pick and choose which measures they're going to support. So if you're shopping for a registry, just make sure that they are supporting the measures that you intend to report on. There are 196 quality measures available to submit through any type of registry. A lot of them are outcome measures, and even more of them are high priority measures. So you can meet that one requirement that one of them be that outcome measure, and again, there's a lot of room there to get some bonus points too by ensuring that you're picking other high priority measures as well. But there are 53 of them that do not have benchmarks. So again, Be careful. Sometimes you need to report on those ones without benchmarks. CMS is going to attempt to create the benchmark through all the folks that report on that this year. But if they do not get enough clinicians reporting on that, then you're only going to receive 3 points for that measure that does not have a benchmark. So be wary. If you can avoid those non-benchmark ones, that might be a good plan to do to ensure that you can get all of your achievement points for it. Again, we stressed this several times. You want to download that CQM specifications and supporting documents zip file. That is very important to understand each and every specification. You want to look through those PDFs that you can get to for each one of those measures. It is vital that you understand all the ins and outs of every one of these measures. So I kind of touched on this. I know when I interrupted Candy earlier, can't stress enough how much record keeping and documentation is vital if you are registry reporting and also claims-based reporting. It is a lot of work, but it's work that you need to do because it does pay off. You have to have some really, really good record keeping and documentation of all of those patients that those quality measures apply to ensure that you have the data you need, especially in case you get audited as well. If you are doing all of that compiling of that data, aggregated reporting through one of the QRs, such as MIPS or one of the QCDRs, can be pretty simple. But again, it's doing all of that front-end legwork to make sure that you're collecting all of that data when it's on the data service if you can, or shortly after. So can't stress enough how important it is to really accurately document all of the data points you need here. So we're going to take a quick look at information needed for our own qualified registry, MIPS. We've got a few screenshots here. If any of and lots of you are using MIPS, I would encourage all of you to. I think shamelessly, it's a pretty darn good tool that we've created. So you can add measures manually from aggregated data that you're compiled throughout the year. This is kind of what that screen looks like when you get to it. We're going to zoom in a little bit here. Once you've logged in, you're looking at just my organization, so that's going to contain just the data about your practice. You've selected quality measures, and you're going to add measures manually, and then you're going to choose if you're reporting as a practice or a clinician, and choosing that from the little drop-down menu there. While you can enter data early to forecast your score, this sample represents the calendar year 2020. So enter the start and end dates that correspond. Reporting year is, of course, 2020. And then for the collection type, you're going to, on the down arrow, because you are registry reporting, you're going to select MIPS CQM. Again, that is what CMS calls their registry measures. They are called MIPS CQMs. You can simply begin keying in the value in the quality ID field, or use the drop-down arrow and scroll to find it. All the other fields are going to autofill once you pick that quality ID CMS number. Here we've selected quality ID 236 again, as we've covered a lot of this information previously. However, note that the measures criteria is different for registry measures as opposed to claims measures. So a lot of these different measures can be reported through the different methods, whether it's claims-based or registry, or if you're EHR, if you have one. But CMS sees that same measure as a different measure based on each collection type. So claims-based reporting on quality ID 236 has different specifications as if you're doing that exact same measure through registry reporting. CMS literally sees it as a separate measure. It is not the same. So each one is going to have its own distinct specifications, and you want to make sure that you understand what those differences are. Next selection shows that the measure selected is an outcome measure. If you'd like more information about that measure, click on that measure details button that's in blue that's going to come up on your screen, which is going to bring up that same PDF that we linked to earlier in this webinar. The fields which you need to be prepared to fill in then, because you've done that copious note-taking and collected all that data, is you're going to enter that performance met, performance not met, the denominator, the exclusion, exceptions, and comments. And don't forget to save measure. There's a big button there that you're going to click each time that you're entering that data to make sure that MIPS is saving it for you. And so how can the data be compiled to fill in the fields for each measure? Again, can't stress enough how important it is to be really diligent about collecting that data. So again, specification examples, I won't go through all this. Candy kind of touched on this. In claims-based, there are some subtle differences here, but kind of gives you what the specification is. We've got those denominator exclusions on this version of the measure as well, just like we saw on the claims-based version. Same thing with, shows you what the numerator is. It is the same. It's the 140 diastolic and 90, I'm sorry, systolic 140 and diastolic 90. And then that additional information, including if no blood pressure is recorded, then it is assumed to be not controlled, just like we saw on the claims-based side. So here's a record extraction example. Again, you want to use some sort of tool to compile this information so that when you go to enter it and you go to submit it to the registry, you go to upload it into MIPS or enter it into MIPS, you got it all in one place. Record extraction is essential. You want to, ideally set up some sort of spreadsheet or something like that that's going to help you control or collect all of this information. Okay, so really today's takeaway is that you can absolutely be a successful reporter for MIPS in 2020 without an EHR. We've sort of been battling this notion throughout each year of the program where folks think they have to have that EHR to get a good MIPS score, even to get a neutral score. That is definitely not the case. It is going to get harder and harder, but I think with some effort, you can at least get to that 45-point mark for this year. But just note that MIPS final score minimum performance threshold is going to increase each year. So we already know that next year it's going to shoot up to 60 points. And it's going to make participating in MIPS without an EHR more challenging each year. So I would encourage you that if you have the ability to bring in that EHR, you're probably going to want to. I know it's a huge undertaking. It's very expensive and a lot of work. But at some point in the near future, you're probably not going to be able to hit that minimum performance threshold if you don't have an EHR. And so you don't want to be on that side where you're taking a pay cut. While EHRs are expensive and they're hard to implement and they've got a host of other issues behind them, I think if you, in future years, maybe even by next year, I don't know that you're going to be able to hit that minimum performance threshold if you don't have an EHR. We've got a host of resources here that are available to you. A lot of these we've already talked about. Some of them are also embedded right in the GoToWebinar interface right now that you can grab. I've got the QPP Resource Center on the top there. That is our portal. So again, that is a free resource to all of you that are in small practices. CMS has these no-cost resources and organizations across the country, but those small and solo practices, the folks that are 15 or fewer billing clinicians, qualify for our free technical support. Please, please, please work with us. I guarantee we can kind of help you navigate this space, especially if you don't have an EHR. I think it is particularly important to work with us. We can take a lot of the guesswork out. We can help you select measures. We can help, kind of talk through those specifications. Just make sure that you're covering all of those bases. So this is completely free to you. Got the link there at the bottom, the qppresourcecenter.org. Click the Join Now button if you haven't already joined up with us. If you are a large practice, you can get technical support as well, but that is really through the QPP's website or the CMS's website, qpp.cms.gov. You can also call their service center for questions as well. So if you are struggling at all for this and you're in this program and you're doing it on your own, don't. There's no reason to be on an island trying to figure this out on your own. There are a lot of great organizations, like the 7 organizations that are working with us here under the QPP Resource Center. We know this stuff inside and out, and we can really help you navigate this space and take out a lot of the complexity. I've got one poll that I need to launch real quick. if you would be so kind, let me get this launched. CMS, because they are paying for us to be out here supporting all of you in this program, they ask us to report back on how we're doing. So if you would be so kind as to let us know how satisfied you are with today's presentation, with 5 being very satisfied. We'll leave this open for just a few more seconds. We appreciate all of you that have voted. We pass this information on to CMS, and if we continue to do a good job, then they will, hopefully continue to fund us and be out here making sure that you guys have everything you need to get the best possible MIPS final score that you can. All right, I'm going to close that poll. Thank you again for giving us that feedback. We really do pay attention to that. Want to ensure that we're doing a good job. Finally, we are up to questions. So I've got information here too. If we don't get to all questions, or if you have something that comes up afterward here, feel free to reach out. Again, we are happy to help. We love getting the questions from you. We love helping you and ensuring that you got everything you need. So go to the QPP Resource Center, qppinfo@altarum.org. We've got a phone number there. Again, we are supporting, there's a network of companies, organizations that are all working under this same umbrella. They all do have their own email addresses and phone numbers. I've only got the one set here, but if you reach out to Altarum, we're going to make sure, and if you're in one of the other states, like Candy is broadcasting from Minnesota right now, if you are a Minnesota clinician, come to us here, and we're going to make sure that we get you over to Candy and all of her colleagues as well. All right, let's take a quick look at any questions that have come in. Doesn't look like we've had a lot. Go ahead.
Yep, I'm not, oh, hi Bruce, this is Candy. I'm not actually seeing any questions in the chat, are you?
I do, I see a few here.
Oh, okay.
So look in the questions box instead of the chat box. So there's
okay.
2 different ones.
Sure. Yep, that makes sense.
Looks like we've had a few here. Let's see. So the first question is, I don't understand if we have to pick a 90-day period for reporting. How is quality measured across the entire year? That's a good question. So we didn't really touch on the different time periods with which you have to report. It can be different from performance category to performance category. So the 90-day period is that minimum date range to report on for the promoting interoperability category, which if you're on this webinar, you probably can't participate in that one since you don't have an EHR, and the improvement activities. Those both have minimum 90-day reporting timeframes. The quality performance category looks at data across the entire year. So it is not just 90 days under quality, it is the entire year. It's the same with cost. Cost is assessed for the entire calendar year as well. So good question, thank you for that. If you are facility-based, but you report your own CQMs, which score will CMS use? So CMS is going to look at both data sets. So if you can be scored as a facility-based provider, CMS is going to try and do that. If you also submit your own data, CMS is going to look at both of those data sets, and they're going to use whichever one of those is most favorable to you. So you always want to make sure that you're doing both. How do you decide if you should report measures for individuals or as a group? No real easy answer on that one. You really have to look at the data. You know, you want to look at it both ways. You want to, and really, you don't really even have to decide that right now. I don't know, Candy, if you'd agree on that. You know, right now, just be getting that data in. You make sure that you're reporting on all of those patients across those quality measures, and get that data into CMS. With claims-based reporting, I think it's a little bit harder to figure out which is better as an individual or as a group. I think this is where working with qualified registries such as MIPS can really help you there, because again, as I mentioned, it's sort of that sandbox. You give us the data, and we're going to help you determine how best to report it to CMS. So we can help you look at it as individual clinicians, and we can, Kevin is actually our MIPS guru. He's going to help you kind of decide, are you getting a better score as an individual, or does it make sense to flip over to group reporting as well? Also, incidentally, I don't think I mentioned this, as a qualified registry, that allows us to submit to CMS on your behalf too. So you'll work with Kevin to determine what that best data set is at the end of the year if you're using MIPS, and then you're going to sign off on that, and then MIPS is going to submit that data to CMS for you. And again, we can kind of help you determine which is better, individual or group. But really, it's sort of a numbers game. You gotta work the data both ways. Sometimes you get a better overall score as group reporting. Sometimes it makes more sense to stay as individuals. There's a lot of facets that go into making that decision, and they're very specific to each and every clinic. So there's no blanket answer there. You just got to really look at it.
And Bruce, we're at the top of our hour.
Okay. All right. So we did get a couple of other questions, but I want to stay cognizant and not go over. So there's a few other questions. Again, just note that you will get an answer. We always answer all of our questions here. So you're going to get an email answer from us on anything else. And again, we're here to help. So once you hang up and you start diving into these claims-based or register reporting or whatever, if we can help you in any way, shape, or form, please don't hesitate. You can reach out to us at the Resource Center, the phone number, the email, everything on your screen right now, and we would be happy to assist you.
Absolutely.
So with that, just want to thank you all for joining us today. Candy, you got any last words?
No, like I said, like you said, Bruce, we just want to encourage everybody to reach out to us. Our goal is absolutely to help as many people as possible be successful reporters.
Exactly. Okay. Well, with that, thank you all for joining us today, and good luck with all of this. If there's anything, again, we can do, please don't hesitate to ask. And with that, have a wonderful afternoon.